Hello again, everyone. So in this talk, I wish to convince you that the breakthrough in molecular testing is to enable the practice of precision oncology, which is defined as tailoring the cancer treatment to the individual patient through the molecular study of tumors to identify targetable genetic alterations in addition to relevant diagnostic and prognostic information. A term that is often used is predictive cancer biomarkers. So in fact, what are they? So these biomarkers refer to prediction of treatment response on the one hand and prediction of outcome or prognostication on the other. So when we focus on prediction of treatment response, you can refer to the identification of drug targets in the tumor cells, be it a positive predictor, that means predicts for efficacy, or a negative predictor, that means predict for lack of efficacy, or the pharmacogenomic aspect in the host to predict for the side effect of treatment. So therefore, non-small cell lung cancer, like adenocarcinoma, can be one disease, but if it is EGFR mutation positive versus ALK rearrangement positive, in fact, there are also two diseases, or even more multiple diseases based on other genetic markers, because these two types of lung cancer differ in terms of the behavior, the treatment, as well as the outcome. If you step back a little bit and think about approaches to somatic or cancer testing, we can have a single gene hotspot mutation test, like a BRAF V600E mutation detection. So that is simple and straightforward. To a single gene, but multiple recurrent mutation testing, like testing for EGFR exons 18 to 21 mutations, or the KRAS exons 2 to 4 mutations. Thirdly, we can have an integrated approach, like, for example, the lung cancer molecular analysis panel of our hospital to detect specific common recurrent actionable mutation in a particular type of cancer. So our LC-map is in fact an integrated histopathological immunohistochemistry as well as molecular testing that target the EGFR, WOS1, and also ALK to give a comprehensive report both on the diagnosis as well as the markers that are useful to guide treatment. And then we can have a disease-specific NGS panel, for example, myeloid gene panel that we are using in this hospital that covers 54 genes that we shall discuss in a minute. And then finally, we can go for a comprehensive genomic profiling. That means to use a large panel, okay, to look at basically all the types of genetic variants that are detectable in a cancer. So I think, in fact, there are much research and also practice of actually using the comprehensive genomic profiling panel because there are clear advantages. It allows a broad coverage of actionable mutations, and it replaces a reflex or stepwise testing, especially applicable to small sample because the sample may not be adequate for a repeat testing in multiple steps. And also a stepwise testing will also prolong your time to result. But however, the disadvantages are that a large panel is more expensive and of course will need a longer turnaround time than single gene testing because of the complexity of the testing. Right, so I think first of all, let's look at this patient, okay? It's a 58-year-old female who presents with anemia and thrombocytopenia So hemoglobin down to 8.5 grams, and also platelet count of only 84. Okay, in the blood, we found 59% blasts, and also the marrow is populated by 46% blasts, and the morphology is that of acute myeloid leukemia with maturation. Flow cytometry picks up the typical panel of myeloid-associated antigens, thus confirming the diagnosis. Cytogenetic shows no growth, and the rapid aneuploidy screen is negative. So we subject this patient to the NGS myeloid gene panel, and we detected 3 mutations. Okay, so there is a 24 base pair duplication in the internal, we call it internal tandem duplication, okay, of the juxtamembrane domain of the FLT3 gene, okay, at a variant allele fraction of 13%, so equivalent to a allelic ratio of 0.15. So that's the first mutation. And at the same time, we detect a slightly longer, so this is a 93 base pair, again, an internal tandem duplication of the FLT3 gene at a lower level. So this time, the variant allele fraction is only 2%, equivalent to a allelic ratio of 0.02. Okay, and then thirdly, we also detect a tetranucleotide CTTG insertion of the NPM1 gene at a higher level, the variant allele frequency of 31%. So the question is, what does all this mean? Okay, so for this particular patient, these results are actually very important because they provide 3 pieces of important clinically useful information. First of all is that the NPM1 mutated or positive and the FLT3 ITD low, defined as a allelic ratio of lower than 0.5, which is the case in this patient, is actually categorized as favorable risk, okay? So the outlook of this patient is more favorable than other patients with acute myeloid leukemia. And this is not all. Secondly, the FLT3 ITD is a drug target, and there is at the present moment availability of 4, and there are more to come, inhibitors of the FLT3, okay, that are potentially useful as treatment options for the patient. And then finally, the NPM1 mutation is a very useful marker for molecular monitoring and minimal or measurable residual disease, MRD in short, detection. So why am I telling you all this? Because as a hematologist, I'm very interested to develop a comprehensive genomic profiling of myeloid leukemia by next generation sequencing, or NGS. So we are the first lab in Hong Kong to develop the NGS myeloid gene panel, and we are doing it since 2014. That sequence the full exons of 15 genes and hotspots of 39 genes. So a total of 54 genes, okay, using 568 amplicons of a size roughly 200 base pair each, okay, to sequence, so coverage length is around 141 kb, aiming at a mean coverage depth of 5,000 folds. So it is really deep sequencing, and a target minimum coverage of 500 folds and 95% exons covered at this minimum. So this panel, okay, basically detects single nucleotide variants and small insertion deletions or indels. So the question is, this is not a comprehensive profiling because it only detects 2 types of variants. So therefore, subsequently, we also develop an RNA sequencing fusion panel that captures the exonic regions of, more than 21,000 exonic regions of 1,385 genes. So this fusion panel detects gene fusions due to chromosomal translocations or rearrangements. But this is, again, is not all. And more recently, we also developed a rapid aneuploidy screen, okay, which is a low pass or in other words, a low coverage whole genome sequencing that detects chromosome gains or loss, okay? So therefore, with the development of these panels, we really can achieve a comprehensive genomic profiling of myeloid neoplasms. And examples are shown in this slide, okay? So the left-hand panel shows the myeloid panel of 54 genes that identifies a TP53 mutation in a case of therapy-related acute myeloid leukemia. Okay, the middle panel shows that the rapid aneuploidy screen, or the low-pass whole genome sequencing, detects a monosomy 7 in a case of acute myeloid leukemia with myelodysplasia-related changes. And then the right-hand side panel shows our RNA sequencing. It identified a rare gene fusion between ETV6 and LIN in a case of acute myeloid leukemia. Okay, so in fact, these testing are not only clinically useful, but in fact, they are rich resource for translational research. Okay, and over these years, we are able to publish on validation of the NGS myeloid gene panel, as well as in collaboration with others, a number of studies on the clinical utility study on the usage of this NGS myeloid panel on various types of patients. And using our RNA-seq, we are able, in 2 papers, characterize very complex chromosomal translocations in 2 patients, okay, using the fusion panel. And then more recently, we are able to complete a study to compare our rapid aneuploidy screen versus a conventional cytogenetics in the detection of chromosomal gains and loss. We started in 2014, and actually over these years, the myeloid NGS gene panel has become a standard of care. Okay, and the uptake is increasing, as shown in the increasing number of requests over the years. So it has become now like a standard practice or standard of care in the investigation of acute myeloid leukemia or other myeloid neoplasms. Right, but we have not forgotten about solid cancer. Okay, so we also developed genomic profiling by next generation sequencing in solid cancer. In that, we have a 93 gene breast and ovarian cancer panel, which covers BRCA1, BRCA2, and the other homologous recombination defect genes, as well as a whole lot of other genes. And also, we have a 72 gene lung cancer panel by NGS that are in clinical service. So in contrast to blood cancer, in which we use fresh cells in the peripheral blood and also in the bone marrow, in solid cancer, we work with the formalin-fixed paraffin-embedded tissue, or FFPE in short, because FFPE is the routine for histopathology, and it serves as an abundant source of archival material. That means you can go back, okay, to the storage and then dig up cases for study. And then it also enables the histopathologist to do a micro dissection for tumor cell enrichment. So looks very good, but however, don't forget that the fixation process, okay, results in degradation or fragmentation of the nucleic acids, okay, typically to less than 300 base pairs. And not only that, it also leads to nucleic acid and protein cross-links and modification of nucleic acids. For example, introducing C to T transitions, okay? That means artifacts which are introduced and should not be there. So in fact, this is a problem or bad news for molecular pathology, because if we work with FFPE, okay, sometimes we encounter a poor yield of amplifiable DNA, and there are also potential for PCR and sequencing errors. So in fact, my suggestion is to actually whether we should consider to test a fresh tissue upfront or freeze up the tissue in terms of banking, where we can go back and study the frozen tissue as a better preservation of a nucleic acid quality and quantity. Of course, I put a question mark here, is that this is not routine in our hospital and also elsewhere. It's because there are lots of issues to discuss. For example, whether there's adequate tissue and whether you have a storage for frozen tissue, etc. Okay, so this is just a suggestion for the future. And on this note, in fact, I'm pleased to inform you that we are now validating a large panel for solid tumors. Actually, this is based on the 324 gene Foundation 1 CDX panel, okay, on a NIC-SIC 550 genomic sequencer. So this panel actually covers 1.8 megabase. So remember that our myeloid panel only covers 141, but now we're talking about larger coverage length and includes exonic and intronic regions for structural rearrangement detection at relevant cancer genes. So therefore, it basically, the scope covers the 4 different types of important genetic variants: the single nucleotide variants, the small indels, the rearrangements or gene fusions, and the copy number abnormalities. Okay, so this is a broad coverage of all the important variants. And also, it gives an added value. Okay, so by computation, it can give a tumor mutation burden, the microsatellite instability, and also a loss of heterozygosity score. Okay. So I wish to share with you some initial results, which are actually quite promising. So we are able to sequence 6 known samples. That means these samples are previously sent off and we have the answer. We have the previous results to base on. And also 1 control sample, okay, from commercial source. So we are able to detect among 120 variants, we are able to detect 94.2%. Okay, and if we look back at the 7 variants that were missed, okay, in fact, in 4, the variant is there, but it's actually below the cutoff. We have a 5% cutoff. Okay, so we need to tune the system a little bit or do further validation in order to pick up these rare variants. And number 2 is actually not our fault, because we found that in 2 cases, in the initial report, okay, the amino acid position reported is different from the reference sequence. Okay, so actually there's something wrong in the original report. And in 1, there's no read cover. That means the panel that's used in the report versus our panel may be slightly modified. Okay, so therefore, lack of coverage in that particular variant. Okay, so overall, the result is quite promising, and we are still pursuing further validation study. Okay, so much on solid tumor. We go back to our case. Okay, so the patient, after induction chemotherapy, achieves complete remission. So that's good news. But the question is how to monitor the patient further. In fact, the concept is that the morphological disease is only the tip of the iceberg. Okay, it's what is beneath the water that cannot be detected by morphology is really important, and that may predict future relapse. So that is now termed as MRD. And our current focus is actually to pursue MRD detection because it's important to provide an objective assessment of deeper remission status. That means we're looking at the iceberg under the water portion to refine outcome prediction and inform post-remission treatment. Okay, and then finally, to identify impending relapse and enable early or even preemptive intervention. Okay, so going back to our patient, the patient has 3 variants, but I just showed 2 of them here. So the first one is the 24 base pair FLT3 ITD. Okay, the second one is the tetranucleotide CTTG insertion of the NPM1 gene. So these 2 are actually length polymorphisms. Okay, they are different in length from the wild type. So in fact, a simple method is to perform a PCR and then separate the DNA fragments, the wild type versus the mutant, okay, by capillary electrophoresis. Okay, so separate them according to length. And in fact, this is doable. Okay, so in the diagnostic sample, this is the FLT3 ITD. So you see the wild type and the mutant. And in the post-treatment sample, okay, the mutants are gone. Okay, but however, we feel that this is not good enough. We want to monitor for deeper levels of MRD. So therefore, we develop a droplet digital PCR, or ddPCR in short, which I already introduced in the previous talk. So we will imagine if there is a suspension of different types of DNA molecules, it is very difficult for rare molecules to be detected. But however, if you partition up the molecules into, for example, droplets, then in a particular droplet, there's a much better chance for these rare events to stand out and to give a signal by PCR. So this is the gist of ddPCR. And so in fact, for the method that we are using, actually in one well, we have 20,000 droplets per well, okay? And then the PCR amplification of the template molecules occur in this individual, in the individual droplets. So therefore, massive sample partitioning is the key. And there are advantages over the conventional real-time quantitative PCR. For example, there's no need to plot the standard curve, shows a superior precision at low levels. So very good for MRD and relatively simple and robust procedure. That means it reduces inter-operator variation. So for this patient, so after induction chemotherapy, although the disease is in complete remission, but however, if we use ddPCR, in fact, the NPM1 mutant is still detectable. So it's complete remission, but MRD positive status. But later on, okay, the NPM1 mutants are no longer detectable. So the patient, okay, changes from MRD positive to MRD negative status. And if we plot the MRD, so the y-axis is the, we're looking at the NPM1 mutation. If we plot the level over time, you can see that in more than 1 year, okay, there are actually 5 time points where the MRD was tested, and they're all so undetectable NPM1 mutation levels. And the patient remains in persistent complete remission. We actually started off the ddPCR service back in 2018. And it also shows that the requests are coming up. That means the clinical demand has increased, and clinicians are really seeing that the test is helpful. So for blood cancer, we target the leukemic fusion transcripts and also gene mutations. But however, don't forget that this MRD concept can also be applicable to solid tumors, for example, lung cancer. And in fact, we can take a blood sample, okay, and do a so-called liquid biopsy, okay, to monitor for the EGFR mutation in lung cancer by a ddPCR method or by other methods. So finally, I wish to submit to you a new paradigm, okay? So the conventional paradigm is that at diagnosis, we do a small panel of markers, and then at relapse refractory disease, we do a re-biopsy or liquid biopsy if the patient is not a surgical candidate to do a larger panel. But what I want to suggest is that we can consider, in fact, we can use more upfront genomic profiling on fresh and frozen tissue at diagnosis to pair with normal to actually detect the genetic susceptibility as well, and do a liquid biopsy disease monitoring, okay, just like a blood cancer, okay, now apply to solid tumor as well, okay, and when there's relapse refractory disease, we follow the same route as before. So I think the advantage of using the fresh tissue upfront is also we can upfront couple with new methods of drug sensitivity testing, like organoid cell cultures. That means we supplement the genomics information with a drug sensitivity data on the tumor cells. And then finally, in the cancer roadmap, okay, the genomic profiling at diagnosis these markers can be used for disease surveillance, okay, and molecular monitoring and MRD detection, okay, and at relapse, okay, to investigate for the mechanism of resistance and to repeat genomic profiling for any additional changes to guide further treatment. But these markers, to me, also have another role or potential role, is that these same markers may also, in the cancer roadmap, be applicable to early detection. This is just a hypothesis, okay? There's actually no data on that yet, okay? But if that's the case, then actually, these markers are applicable in every stage of the cancer roadmap. And with this, I close. I apologize for slightly going over time, but I wish to thank Dr. Chris Chan and all-star molecular pathology lab, and to referring clinicians, and also to patients from whom we learned a lot of useful information. So thank you very much.